Welcome, everyone. Let's go ahead and get started. I know that we all have busy days, and so I'm going to jump right in, cover a little bit of background and housekeeping, and then we will get to our presentation and panel. My name is Alexis Whittam. I am the Director of Communications for the Colorado Coalition for the Homeless. And this is our education series that we do not quite monthly. We do about 8 or 9 per year, primarily virtually. And the idea is to be able to take the time to deep dive about one issue related to homelessness and spend a little more time talking about that. So sometimes we'll do a homelessness 101 where we're talking really broadly. But a lot of times what people want to know is sort of more in the details talking to the people who work directly with clients or people who have experience with homelessness. And so today we're really excited to be able to take a deep dive into integrated health and its connection to housing, its connection to working to resolve homelessness. So let's go ahead and head on in. So we're going to start with a little background on health and homelessness. A lot of this comes from our health and homelessness report, which came out a couple years ago and has some pretty broad strokes. And one of my colleagues can pop in the chat for you the link. You can also find it at coloradocoalition.org and .org/reports. So my colleague Andrew West is going to go ahead and present for the next few slides, and then it'll come back to me before we head into our panel. So Andrew, over to you.
Yeah, thank you so much, Alexis, for kicking it off, getting us started today. I'm Andrew West. I'm the policy associate here with the Coalition for the Homeless. Appreciate you all joining during our special lunch hour Ed Series presentation. And I'm going to be giving an overview of integrated health and what that means. And primarily, it is a client's ability to be able to address their healthcare and housing needs through the same organization and oftentimes at co-located sites. And we recognize that housing is healthcare at the Coalition and that safe and affordable housing is one of the foremost solutions to the health problems that are faced by people experiencing homelessness. I'm going to set the stage quickly, as Alexis mentioned, with some background information. Some of this is from our 2023 report on health and homelessness that shows how poor health and homelessness are unfortunately often shared experiences. We know that homelessness can be very physically taxing, but also harmful to mental and emotional well-being. And while experiencing homelessness, people are really exposed to a multitude of factors that people who are otherwise housed would not experience that can make it really difficult to address their health needs and regain stability in a lot of ways. So as a result, we know that homelessness is associated with really severely reduced life expectancy. We know that from different studies, and there are lots of different estimates, but we know that there's approximately a 15 to 30-year reduced life expectancy for people who have been unhoused for long periods of time. And that is because of, like I mentioned, the really multitude of factors that make it difficult to address their health needs. We also see an increased likelihood of experiencing violence. I think there's a common myth that people experiencing homelessness are actually they are aggressors, but we know that from a lot of data, people who are experiencing homelessness are much more likely to experience violence than actually be a perpetrator. And we'll talk about that a little bit more as we go on. There's also an increased risk of traumatic injuries and assaults just from being exposed to really difficult conditions while living without stable shelter, as well as weather conditions that can include extreme heat, as we've seen here in the last few weeks. This extreme heat can be really dangerous. And then during the winter months, we talk more about the cold, frostbite, hypothermia, and adverse weather conditions related to cold. And overall, I think one theme that's going to be recurring throughout the session is something that we often hear from our doctors and clinicians at CCH, that if they could prescribe housing the way they do medication, they would. We know that housing is really the cure in a lot of ways to homelessness, as well as a lot of the medical conditions that often accompany experiences of homelessness. One thing I also want to talk about is adverse childhood experiences. I think this is really something at the foundation of a lot of these different health issues and something that we don't talk about all the time. This is one thing that we highlight in our report, but adverse childhood experiences are traumatic events that occur in childhood. So often at a young age, when these things are experienced, they can be very traumatic and have later effects on health throughout life. And the way that these are conducted is through a test of adverse childhood experiences. It's 10 questions, and you simply answer yes or no to whether you have experienced different types of violence, abuse, neglect, substance abuse, etc., in your family. And essentially, these are all different experiences of childhood, of trauma, I'm sorry, in childhood. And this can include witnessing violence in the home or community, having a family member go through struggles at various times of their life, and growing up in a household with people who have significant issues like substance use disorder, mental health conditions, instability due to parental separation, or household members and family members going to jail or prison. And we see that at the level of experiencing these adverse childhood experiences, there can be a lot of stress related to childhood development, including the immune systems, stress response systems that make it harder to manage chronic health problems, mental illness, and substance use later on in life. And of course, there's a host of negative impacts that are seen with these childhood experiences. Next slide, please. Thank you. So there's a lot of research on these ACEs and their connection to homelessness. This purple chart here that you'll see is from a report from Washington State, and it shows the percentage likelihood that someone experiences homelessness based on their ACE score, as it's referred to. And we see at number 4, that's the area where really serious health impacts begin to be seen. From 4 on, that's considered a high score, and about 54% of people experiencing homelessness report a score of 4 or higher, compared to 3 to 5% of the general public. So we see that these high ACE scores are really closely tied to one's likelihood of experiencing homelessness and housing stability later on in life. All right. And I'll also mention that while trauma is sometimes a cause of homelessness, trauma is often a result of homelessness. So if you haven't experienced a lot of trauma before experiencing homelessness, we know that once you're living without shelter, you're much more likely to be exposed to these kinds of traumas as well. I'll talk about some chronic health conditions and exposure. We know that chronic illnesses are both more prevalent and more severe among people experiencing homelessness. So we find really increased rates of conditions like heart disease, diabetes, and respiratory illnesses at a rate, depending on the study, about 3 to 6 times higher than individuals who are housed. We also see that health conditions can mirror those of someone 15 to 20 years older. So a lot of times if clients come into our health center at the age of 40, they can be experiencing conditions that are more comparable to someone in their 50s or even 60s. And our clinicians know to treat folks in that way because of their experiences. They know that they can expect oftentimes for someone who has been unhoused for a long period of time that they will display conditions that are more typical of someone that is older. We also know that there are a lot of consequences of housing instability. I'll give a few examples here. Again, these are all ones that we go into deeper depth on in our report, so I definitely encourage you to check that out. The first one being lack of sleep. There was one good study that looked at a demographic of people who are experiencing homelessness, and they asked in the last few months, how often have you been able to get a good night's sleep? And they found that people who were sleeping rough, so people who are experiencing unsheltered homelessness and sleeping on the street, oftentimes only get really fragmented sleep because they can be interrupted throughout the night. And the majority of survey respondents got 2 hours or less of uninterrupted rest throughout the night. I think recently there's been a lot of great research on how important sleep is to well-being across a lot of different areas. And we know that not being able to get that sleep makes it so much harder to manage any health conditions that you might have that are ongoing. We also know, as I mentioned before, that unhoused individuals are much more likely to be victims of violent crime than perpetrators. One study reported about 50% had endured a violent attack in the last couple of months, and 62% had witnessed violence against someone else who was experiencing homelessness in that same period of time. So again, people are much more likely to be victims of crime than the perpetrators. And then the third area is chronic pain. One study found that about a little over half of unhoused respondents in the survey reported chronic pain. And another found that 37% described this pain as highly disabling, so that not only that they had chronic pain, but that it made it very difficult to perform routine daily functions and access employment and those kind of things due to the severity of the conditions. So those are just a few of the consequences of housing instability, but I think are some that we don't talk about as much and should be highlighted. And then we look at complex needs and comorbidities. This really means multiple chronic, both physical and behavioral health conditions at the same time. So we've got co-occurring conditions like diabetes, cardiovascular disease, respiratory illnesses, substance use disorders, mental health issues that can really make each of these issues more difficult and tangled when they're treated. So again, these are much more likely to be found in people experiencing homelessness and make it difficult to address any of these conditions alone. And then unstable housing creates a lot of barriers to care. So it can be much more difficult, obviously, to manage medication, attend regular appointments, engage in treatment plans when you don't have a stable place to call home. So what works? I presented a lot of data that shows some of the difficulties and struggles of people experiencing homelessness, but what are some ways that we can look towards solutions? This is obviously something that we'll hear more from our panelists who have much more hands-on experience and expertise in this field. But we know that an integrated approach, co-locating different types of services reduces barriers to access. So people are able to access more services when they are co-located and when they're easier, when they're better facilitated. We offer a wide range of primary care services, including preventative treatment, managing conditions before they get worse. And once conditions become more severe, it's obviously more difficult to treat them. We also offer a wide range of mental health treatment and substance use disorder treatment at CCH, and we know that these things are very important as well to resolving homelessness. We've also got some slides that will talk about recuperative care and respite care, and our overall approach to integrated housing and healthcare at CCH. So with that, I will pass it back to my colleague Alexis to give a bit of a more in-depth overview of how we provide integrated healthcare at CCH.
Thanks, Andrew. Appreciate it. So that was sort of the broad look at what's working to resolve homelessness and what people experiencing homelessness experience in terms of their healthcare and health needs. I'm going to talk a little bit about the coalition specifically because the majority of our panelists today work at the coalition. And so to understand where we're coming from and where their expertise comes from, you kind of got to understand a little bit more deeply how we serve folks. So at the coalition, we serve about 22,000 people each year, and almost 15,000 of those are supported through healthcare. We have essentially a federally qualified health center or community health center that is the Stout Street Health Center, but all the ancillary locations count as well. So the Stout Street Health Center is sort of our mothership, 50,000 square feet, located on Stout Street in pretty much downtown Denver. But we have other satellite places as well. So the 48th Ave Health Center is co-located within the shelter out on 48th. And so that's a really wonderful way for folks who are staying in shelter to be able to access healthcare. Before, people would have to take two buses maybe to get to an appointment, and now they can do it right there. And then that leaves them more time to work on the other things they're working on while they're in shelter, right? Working on jobs, getting signed up for benefits, whatever it is that their priorities are. We also have the health outreach program, which is our RV that travels from site to site, goes to some of our partner locations of organizations that also work in the sector, goes to some of the city of Denver spots as well. The West End Health Center is sort of on the west side of Denver, closer to Sloan's Lake, and so that serves folks in that area. We also have Fort Lyon, which of course, if you've come to any of our sessions, you've probably heard about Fort Lyon, but that is our dedicated substance use recovery campus down in Southeast Colorado. And so that is a federally qualified health center down there as well. We have our recuperative care center, which helps people in that gap between when you're released from the hospital and they say you're well enough to go home, but you don't have a home to go to. The John Parvensky Stout Street Recuperative Care Center helps fill that gap, and folks can stay and work on resolving a specific issue. We also do street medicine, and we also deliver healthcare to people in our housing. And so it'll be great to talk to some of our panelists today about how exactly that happens. I'll also mention that the Stout Street Health Center is one of 21 community health center locations in Colorado. CHCs provide healthcare for more than 850,000 Coloradans. So that's 1 in 7 people in the state, including 23% of Medicaid enrollees. And so Holly Kingsbury is going to be on our panel from CCHN and going to tell us a little bit more because as much as what the coalition does is unique to serving the population of people experiencing homelessness or at risk of homelessness, we're also just one of these many community health centers that are working to serve people throughout the state and throughout our community. So what services do we provide? It's everything. We've got primary care, we've got healthcare for children, psychiatry, nurse visits, including wound care. Wound care is a huge specialty for many of our nurses, and a large part of what we do because living outside can be really rough. Exposure to the elements, exposure to weather. That's a big part of what our nurses do. We have dental care, both at the health center and some sort of special days at some of our other locations to do dental care. We have an eye clinic. We have a pharmacy that's twice as busy as your average Walgreens because of the number of medications that folks need due to acuity with our population, as well as just sometimes prescriptions are lost, they're swept, things like that. Medication assisted treatment to help people who want to work on their substance use disorders, including just drop ins for that. Case management, behavioral health for therapy and groups, and then Medicaid enrollment assistance, especially as we look towards potential cuts for Medicaid. It's incredibly important that if you are eligible for Medicaid, you can access your Medicaid and not get lost in all of the difficult paperwork. So we do have benefits enrollment specialists at CCH as well. So a couple of quick data findings. We're really lucky at the coalition to have an internal quality improvement and insurance assurance team, the QI&A team. And what that means is that we have data folks on site who are part of our organization who can really deep dive into some things of how it works at an organization that's doing healthcare and housing. Very few organizations are doing both of these at the level we're doing them, right? We've got over 2,000 people in our 23 properties who are in permanent, supportive, affordable, or transitional housing, and we have this federally qualified health center serving 15,000 people. So the data that we're able to get from that cross knowledge is really something that a lot of folks don't know that we are able to have internally, and that really helps us to understand more of how people experiencing homelessness are impacted by the co-location of these services. So this first slide here is about specific to supportive housing clients. So these are people in the permanent supportive housing that we have. 61% of these clients receive more than one service type. So folks are engaging with case management and they're also getting medical care or healthcare, psychiatry, dental vision, something else. So that's great. You're working on one thing, you can work on others as well. 46% of these housed clients have had a medical visit. Now, remember, some people, like we have a whole veterans facility. Those folks are generally getting their medical through the VA. So not everyone wants to engage with us for medical care. Maybe they like Denver Health, maybe they like the VA. Great. But almost half of our clients who are in our permanent supportive housing are having a CCH medical visit. 41% have had a behavioral health visit and 20% have had a psychiatry visit. So all great outcomes. Next slide, please. These slides, the next couple are about people engaging with our services regardless of whether or not they live in our permanent supportive housing. So just want to make sure that that's known in our data beforehand. So the longer people engage with CCH, the more services they receive. And so what that means, you can see these percentages they go up. The longer that you're here, you're going to get more and more services. And that's great. Once again, a lot of people have to resolve thing A before they can do thing B. And so people are able to engage more the more they're engaged with us. And oftentimes, the more trust they have in our organization and in the kinds of people like our panelists today who work with clients and earn that trust over time. People engaged for over 10 years were the most likely to have engaged with behavioral health or substance use disorder care. So once again, we know that people experiencing homelessness disproportionately have some mental health, behavioral health needs or substance use needs. But the longer that they are with us, the longer that the more likely they are to engage in those services. There's also just the time and service use correlation. So you'll be engaged, you can see the encounters essentially go up the longer that you've been in our services. So number of encounters matters, right? If we want people to not have to go to the emergency room for their health needs and for the cost that is to taxpayers if they can't cover those costs, we want them to have more encounters. We want you to do preventative care. We want you to see the pharmacist. We want you to be on your medication, right? It's better for that person if they're having more encounters. And so the more people are around, the more encounters they have. And then this is also interesting. It's just the overall number of encounters in our different areas that we have. And so you'll see that supportive housing is where a lot of people have encounters. A lot of those are case management encounters. So the way that it works is you're engaging with your case manager and you're saying, hey, I want to work on this or that, right? And if your number one thing is dental, then that's what your case manager is going to help you with, whatever it is that you want to work on. So you can see that we have a very high number of encounters in something like supportive housing, and then we have the least in vision because, not everyone like me needs vision care regularly. So just an interesting way to look at this. There's also UDS data that we provide every year. You can always Google it and see, who we serve and populations and all that. But this is just some data that zooms in a little bit on stuff we don't usually have the chance to like dig in and talk about. And now we finally do because we're taking this session to do so. This is just one. I just want to take a moment and talk about a change that was made recently to our integrated case management that just demonstrates that, look, we've been doing this 40 years and circumstances have changed. The types of people needing services have changed, right? We have more families experiencing homelessness than we used to. We have a lot of people new to homelessness. So we transition the way that we help people and provide them services based on what we hear. And we do try to be data-based if something's changing. So essentially the way that it used to work, if someone wants to come in and they're like, I want to get on a housing list, I want to engage with CCH for services, we are not able to just help everyone who comes in that day due to capacity. And so the way that it worked before is people would wait in person. They would line up outside on downtown campus, outside of our building, and we would take people in line. And people used to line up an hour before, 2 hours before. And over time, as more and more people were experiencing homelessness and had more difficulty accessing services, people were coming as early as the night before. And that was really felt like that wasn't a responsive way for us to assist people if people are camping out outside of our facilities, right? So our team went ahead and talked about how do we fix this to make this better for people and what do we think would work, but what can we data prove actually works? And so one of our members of the QI&A team started meeting with people who were in line or who were trying to get services and just asking, do you have 2 minutes so that I can talk to you about how this process is working and what would work better? And over a number of weeks, they spoke to clients. They spoke, of course, to case managers and people on site, and they said, what could work better? And so now we have an online form that's open for a week prior to the date. You also can sign up in person. We know that not everyone can get online, right? So you can sign up in person or online. It has a plan of when we'll tell everyone on Monday if you have an appointment for Wednesday, you get a phone call, but you also can come back and ask us. And it's just a way that this collaboration worked in order to make it easier for people. But the other thing that we did in this process was also figure out how can we make it more integrated so that when someone comes in, we can get them more quickly figuring out can you meet that same day both with case management and behavioral health on the day you come in so that you have more access to getting the ball rolling on more things at once? You can integrate into more of our services at once. So this, according to Christine, our manager of client access at Stout Street Health Center, it breaks down silos, improves efficiency, and gives our clients the care that they need in the way that they need to receive it. It's holistic support. So we'll go to the next slide, and I believe that what we're going to do is introduce our panelists. So I'm going to just give a quick little description of everyone, and then we're going to go ahead and jump in. So first we have Susan Hudson. Susan has been a case manager since 2016 and has worked with the unhoused population since 2018. Susan also works in cold weather street outreach during the winter and enjoys working on the HOP, the Health Outreach Program RV vehicle, when she has the chance. So, welcome, Susan. Holly Kingsbury is the Quality Initiatives Director at the Colorado Community Health Network, or CCHN. CCHN is the primary care association for Colorado, representing the 21 community health centers in Colorado, the largest primary care network in the state. Holly joined CCHN in 2015, and in her current role, she oversees the quality improvement, practice facilitation, and technical assistance work of the Quality Initiatives Division, supporting community health centers in areas such as medical, dental, and behavioral health integration, emergency preparedness, disease prevention and detection, and team-based care. Welcome, Holly. Winnie Promise is the On-Site Housing Support Services, or HSS. You'll hear us use acronyms sometimes, so always ask if I'm doing too many. Program manager overseeing case management teams at multiple sites. HSS provides comprehensive wraparound services, including case management, behavioral health, and psychiatric support, peer services, crisis intervention, domestic violence / survivor support services, housing stabilization, and resource linkage. Winnie has been with the coalition for 2 years. Welcome, Winnie. And finally, Karen Spring has been a registered nurse since 2006 and a family nurse practitioner for 15 years. Karen has been with the coalition for 8 years, providing primary care for adults experiencing homelessness or with a history of homelessness. She has specific interest in HIV care and prevention, as well as gender-affirming care. Karen practices in clinic at the Stout Street Health Center and also provides direct primary care services at 2 of our apartment buildings, Forum Apartments, and the Renaissance Downtown Lofts. So welcome, Karen. All right. So I'm gonna go ahead and start the way we always start these, which is we did this long data presentation. It was longer than I said it would be. I'm sorry. Is there anything we missed? Is there anything as we go to talk about healthcare and people experiencing homelessness that you think it was missed here? Or is there anything that stood out to you as interesting that you weren't expecting? And that question is for anyone who'd like to answer.
Well, I'll take that if no one else is jumping in.
Sounds good.
First of all, I thought the presentation was great, and I actually learned a few things, which was also wonderful. I guess the only thing I have to add is every day, all of us doing this work, we're coming together with the same goals in mind, and really trying to put patients at the center of that. And the only way we can possibly accomplish that is by having a wraparound team involved in that care.
Thank you. Anyone else? No reason that you have to answer this question. It's totally optional.
I'll just add, I'm
For
always,
me,
oh, go ahead, Winnie.
yeah, thank you. It was really an informative presentation. Thank you very much, Andrew. What stood out for me was the numbers. Data does not lie. The over 53% of people experiencing homelessness are reporting having gone through, these adverse childhood experiences. So, I mean, that correlation shows that most of our clients have gone through trauma. And what stood out for me is whether we're actually even having these conversations across the board, not just, us, the specialists, the case managers, the behavioral health teams, the psych teams, whether we are having these conversations, the trauma-informed conversations, even with, property management. And this is a very good start that we are having these learning sessions for the coalition for us to, have an understanding of our clients. It's very, very important to understand the people that we serve. And I mean, how early trauma leads to chronic health issues like mental health, untimely housing stability, and having that understanding that homelessness is not just, a housing issue, it's a public health crisis rooted in trauma. And this is where our integrated care comes in as a coalition, and understanding that this is the point where people begin to heal, where our clients begin to heal. So these conversations are very healthy. They shouldn't even stop today, but we should continue having these conversations and retrain ourselves to understand the clients that we actually serve. And when you say wraparound services, hey, I am all for it, but how informed are our teams, including property management, hard, mention it. You can go across the board. So that was what I wanted to add to this discussion for now. Thank you.
My takeaway was pretty similar. I'm always just so struck by that data related to adverse childhood experiences and the connections to homelessness later in life. And I think it's just such an important reminder that you never really know what someone's bringing into the room with them when you think about all the different ways someone might access a health center. And I think, as Winnie said really well, like why it's so important to provide that patient-centered whole person care.
Thank you. And I think I'll actually jump to another question here. I'm going to jump to Karen for this question because we had a couple panelists bring up trauma and trauma-informed care. And, it's something we didn't cover in the presentation because I thought it was long enough. But I'm hoping that you, as an expert in the field and someone who works directly with clients, we talk about when I've done presentations with some of our medical team when we go to med schools and talk to people in the sector, and we talk a lot about our harm reduction and how we use that as a model outside of just substance use disorder, but just generally talk about harm reduction and also trauma-informed care. And so, Karen, as a nurse, I was hoping that you could tell us more about like how these two things work and sort of how you use them in your day-to-day work or you and your colleagues do.
Sure. We approach the care of our clients and our patients on the assumption that everybody has trauma that we're encountering. And it's kind of the chicken or the egg. Did they have the trauma before homelessness and that led to homelessness, or do they have the trauma because of homelessness? And usually the answer is yes. It's because of both. And so when we approach care with that lens, we're thinking about setting up the structures and the access within our clinic in a format that works for more people than many other traditional healthcare settings. And it doesn't always work for everybody. It's never going to be perfect, but we're constantly reevaluating that model and thinking of ways we can be creative to meet people's needs. And then that trauma-informed approach continues into the folks that are working directly with the clients. Myself being one of those, but along again with this multidisciplinary team. Frankly, I think somebody who doesn't have a trauma-informed lens wouldn't fit in with us because we're all looking people in the eyes, which is a privilege. A lot of the folks we're encountering don't get acknowledged. They get looked over in many facets of their lives in society. And we sit down, we look people in the face, we listen to their stories, and we identify what their needs are, and then we build from that. And that's, I guess, how I mostly see trauma-informed care. And that melds in well with harm reduction. Harm reduction is basically a concept that our actions aren't necessarily based on what works for everybody and what's best for everybody's health, but instead it's looking at this individual, listening to them and understanding where they're coming from and trying to identify ways that can improve their health, improve their wellness, improve their situation that may not meet standard definitions. For example, I have a patient who has used methamphetamines for many, many, many years, has been injecting for a very, very long time. And she started smoking meth. And that was a great opportunity to talk about the health benefits of that. That's harm reduction. We had talked many times about the safety with needle exchange and her use and whatnot. And she ultimately made the decision that she just wasn't going to inject anymore. And we reflected on the greatness of that decision. And do traditional parameters say, yes, not using meth would be the safest choice for her health? Of course. And we can continue that conversation and we continue on that journey. But meeting her where she was at that point in time and acknowledging the positive health change she made, that's harm reduction to me.
Great. Thank you so much. And I'm going to take a little step back. We are talking a lot about CCH and what we do, but as I mentioned in the presentation, we're one of many community health centers in the state of Colorado. And so, Holly, I wanted to talk to you a little bit about like what sometimes I say these words, I'm like CHC, FQHC, and what are community health centers generally and how are they different in different regions and how are they maybe different than the coalition, which is specialized to help people experiencing homelessness or at risk of homelessness? Like what do other community health centers look like and how do they sort of serve populations throughout the state?
Yeah, I'm happy to share. And you gave a great brief intro to health centers earlier. So as Alexa said, there's 21 community health centers, also referred to as federally qualified health centers in the state. And they serve all patients regardless of their ability to pay or their insurance status. And Alexis shared some of the data around what those patient populations look like. One of the things I think that's really unique about community health centers as a whole is that they're required to have patient majority boards. So that means that 51% of their board members at minimum must be patients of the health center. And so that allows them, regardless of where they are in the state, to really be driven by patients, and ensures that they're meeting the needs of the community, that they're hearing the needs of the community, and that's coming through in the board, and then the services they provide. And so Colorado, I think, has one of the largest health centers in the state in Denver Health, and also one of the smallest in Uncompahgre Medical Center out in Southwest Colorado, Norwood. So really a wide range of urban, rural, and frontier, a wide range of sizes, a wide range of patient populations. Like at the Coalition, many health centers provide healthcare in integrated settings. So that means that patients can be connected to medical, dental, behavioral health care, substance use disorder treatment, and pharmacy, regardless of what they initially come to the clinic for. And I think just the list of services that you shared in your presentation really highlights the breadth of what might be available. Coalition, I think, is unique in really the housing focus, wraparound services focus, and the focus on patients who are experiencing homelessness, who are at risk of homelessness. But there are, I think, 3 other health centers in the state who receive similar federal funding to serve those patients. So some kind of like sub peer groups there. And then I think the only other thing I would note is a lot of the innovative practices that the coalition employs around integration, like having a dental hygienist in primary care, in a primary care clinic, or providing a warm handoff to a behavioral health provider, have spread around the state. And so that's something I think that through different peer groups, coalitions had the chance to share and really share your innovative model and also learn from others. And I think that's something somewhat unique that happens in Colorado as well, that we're able to spread those best practices around the state.
Great. Thank you so much, Holly. So Susan, I want to turn to you. You work as a case manager for the Department of Outreach and Engagement. We call it the DOES Department, Outreach and Engagement Services. This is often the first stop when a client is new to working with the coalition and a case manager. Can you tell us more about the integration of client access to housing and case management, health services? How does that work for you as someone who's working specifically on the DOES team?
Well, for myself, I work out of the Stout Street Recuperative Care Center. So clients that come in here, they come in because they don't have a place to go after the hospital discharges them. And my job is to get them what they need while they're here. So we immediately start working on vital documents. Do they have disability? We get that. We get SNAP. Do they need long-term Medicaid? Do they need to go to long-term care? Do they need sober living? Anything along that line. But the most important thing is I get to work one-on-one with providers. So I am able to go to a provider and sit down and say, this is this client, you're seeing them, I'm seeing them. What is going to be the best decision for them to make regarding where they're going to go from here? And we're able to reach out to those to assisted livings or to sober livings or to Fort Lyon and see where we can help a client go that's going to be more successful for them. If they come into the health center, they're automatically assigned a case manager when they come in. They can have long-term case management over there. Once again, we work with providers to see what's going to be the best type of housing for them, what they want, what documents they need, because we all know they need all their vital docs to get into housing. That's first and foremost the first thing we're going to do for them. PATH, you've already talked about the PATH program, where they get in and they speak with mental health right away. And for me, it's really great because I can take my clients and I can say, you're having a really bad day mental health wise here. Let's get you hooked up with this person over here that can help you. Or let's get with this doctor over here that can help you with your medical issues and your pills that were stolen or what have you. So it's really helpful that we are able to to work with the providers along with the clients and housing them so that we get them somewhere where, not that we're going to put them there, but somewhere where they can go, where they're going to be successful and stay housed and get the care that they need.
Thanks so much, Susan. And I think that's an interesting point that we've only had the recuperative care center as it is now for a little over 2 years. And so before we had about 15 respite beds and now we have 70, 75. And so some of the clients are coming in because they're physically qualified to come in and have a physical concern that is going to resolve over the course of their stay. And some of those people, I would assume, have been a coalition with the coalition in the past for healthcare or with the case manager or whatever, but because they're not necessarily already engaged, you are getting people who may have been experiencing homelessness for years and years, or maybe just a month, and they've never engaged with the coalition. And so you're able to come in and they're on site, they're talking to doctors, you're talking to those doctors and other providers. And so it is really integrated in one place in a way that can be hard to do generally. So that was great to share that how you're doing that within recuperative care. Were you before you were doing this here, were you doing DOES generally before, or has it been like different to do this type of work? Because you've been a case manager for a while, so is it different to do this kind of work at this site than some of your previous times?
Yes, I actually worked out of the women's shelter at 48th, and it's Smith Road for quite a while. I was there before COVID, out during COVID, and after COVID.
Yeah.
So it is different to be able to be here and to have others that are supporting me. It's not just me working with somebody, it's a team working with somebody. And that is the best feeling I think I can have. And here at Recuperative, we get quite a few people that are first-time homeless.
Mm-hmm.
They've never been homeless in their life. They wound up in the hospital. They're homeless now. They don't know what to do. So being able to be there for somebody and to walk them through that process is, I want to say it's a great feeling, but it's just nice to know that there's somebody there for them that can help them through the process.
Thank you so much for sharing. And if anyone wants to know more about our recuperative care center, there's a short video on our YouTube page. It's like a tour from right when we opened up. So it has a few things that are a little out of date, but if someone can drop it in the chat, it's like 7 minutes. Susan?
And really fast, our outreach workers for DOES, they also work with street medicine outreach. So while they're helping clients that are out on the streets, they hook them up with street outreach medicine as well.
Great. Thank you so much. So, Winnie, you are part of Housing Supportive Services at CCH. And so what that means is you and your coworkers assist people on site who live within our permanent supportive housing sites. Can you tell us a little bit more about how the HSS team works with clients on their healthcare goals specifically? Winnie, you are muted. I'm not sure if you're speaking, but you're muted.
Yes, I was speaking.
Okay.
So at Housing Supportive Services, HSS, our team plays a critical role in helping our clients maintain housing while also pursuing stability and improved health for them. Because we understand that stable housing is a platform for health. It's also a way that our clients face complex physical behavioral needs and making sure that those needs are actually addressed. So our work is grounded around trust, consistency, meeting clients where they are, but also helping them support those health care goals. So in doing that, we have an integrated care coordination kind of approach to our work where we collaboratively work close to the medical teams, the psych teams, the substance use provider teams. We have peer supports at our properties. And these teams, of course, with our case management, help coordinate these internal but also external processes. And this is to ensure that our clients receive the right care and at the right time. So our case managers help bridge the gaps in communication with these internal and external teams. And we are becoming more intentional in our conversations, in our collaborations to make sure that the loops are actually closed. There is something we have started recently where The psych teams and the behavioral teams meet with the case management team, with the programs teams, and we are intentionally discussing client referrals, client issues, who has been referred, who is still resisting referral, what are those gaps to the whole referral process. So these streamlined conversations that we have across the teams is making service delivery better. We are not yet there, but we are becoming more intentional in bridging those communication gaps. And we also have an interesting process, which is called the housing retention process, the HRC process, where it's like a communication hub for property management, case management, myself as a manager. We have sometimes even the behavioral health teams come and sit in these meetings, and we are discussing client housing retention goals and also other challenges that would affect those housing retention goals. So while we are in these meetings, we are also educating ourselves on TIC, for example, because we have realized we are not all at the same level, especially with the property management teams, even case management. We come from different backgrounds. So we use these spaces to discuss clients, but also to provide, transparency for both us and our clients, and provide informed decision makings, because all the decisions we make affect our clients. So we are having, educative conversations and agreeing as a group, as a team, as a hub, to decisions that might affect our clients. So those must be trauma informed. There must be, an element of harm reduction even as we make these decisions. The other element, of course, is wellness planning and harm reduction. We support our clients in creating personalized and wellness plans that are realistic to them and are meaningful, because case management should be able to also be able to communicate with behavioral health. What are those things we are identifying or observing with those clients, and what more support do our teams provide for the client? So we are having more meaningful conversations with even the other teams to provide those personalized health and wellness plans for our clients. And we have seen this, of course, improve medication routines. For example, I had a client who was missing appointments for her psych appointments, and the psych team leader reached out to me saying, "Hey, one of your clients is missing appointments." And when I was probing with case management, why is this person missing the appointments, I realized it was even deeper than just reminding the client of going for their psych appointment. So that's why I come in as a manager, like to really, really dig into why is this person missing their psych appointments. And we came to realize that person actually had dementia. They didn't even remember these appointments that they had them. So how do we now provide support for this client who has dementia but has to go for their appointments? And that's where we come in to provide transportation, literally take the person to their appointments to make sure that that gap is filled. So case management teams are going above and beyond to ensure that our clients are receiving the services they need. Then the other one, of course, is supporting crisis response and stabilization. At HSS, we have a unique cohort of clients. Most of them are high acuity, and we receive, crisis reports on a daily basis at our different properties. So how we manage that is very important in, of course, one, supporting the client, but also maintaining their stability, because when property management reaches out to us, we must be able to fill that gap, especially when there are crises at the properties. So what we do, we coordinate with the safety teams, case management, behavioral teams to ensure that crisis is managed at that level. And we provide harm reduction, trauma-informed care at that point. Medication support, you will not believe it, but our staff are providing, medication support and adherence. There are clients who may have, cognitive impairments, mental health issues, literacy barriers. We have staff like case managers who are going above and beyond to support clients with those medication reminders, storage for their medications, reminding them to go for their clinical appointments. So it's those small, small things that are helping our clients even be more stable. And another one is also the empowerment through peer support. I'm glad that even other programs are incorporating peer support as part of supportive services. We have peer support at the properties that we serve, and these peer support specialists provide lived experience to support clients in navigating, the healthcare system, overcoming stigma, providing motivation for our clients, but also keep them engaged in services. And lastly, but not least, transportation and logistical support, because we know that some of these barriers are what hinder integrated health. So, we help our clients get into the appointments. We are driving them to appointments. We are providing, bus tickets to the appointments. We are reminding them of their medical appointments. So we are trying to reduce barriers that may otherwise prevent clients from engaging in healthcare consistency. So in a nutshell, that is how HSS supports our clients in integrated health. Thank you.
Thank you so much, Winnie. And I think folks can see just how complex our organization is. So I work in communications and I could never explain what HSS does nearly as well as Winnie just did. So I'm so glad to have this opportunity to learn from my colleagues and from Holly about sort of the sector in a way that our advocacy and education teams cannot quite keep up with. So this question is sort of more taking a step back. We called this session Why Integrated Health is Critical to Solving Homelessness. And I just want to say, for you all, in your professional opinion, why is it critical to solving homelessness? I heard from Winnie that, there's a lot of work to be done. You may be driving to someone's appointment, you may be reminding them, but sort of big picture or a small picture just for you and maybe one client you work with or generally clients you work with, what is sort of the answer to why it's important to have this integration from your perspective? And start with whomever.
I'll go ahead and get started. When I'm thinking about our clients, and we've spoken about the trauma that many of them present with, a lot of that is medical trauma. And so as a medical clinician, that's of course always at the forefront of my mind. And in thinking about ways to be able to support them to do essentially my job, support them in, their journey on their health, I need support in helping to navigate that trauma in a capacity that they're ready to do, and helping to meet their identified needs, which may not always be the medically identified needs, and I'm simply not the best person to address them. And so it's not unusual for me to come in to see a patient or a client, and I ask them, what do we need to address today? And they tell me, well, I need housing. Say, okay, so I'm hearing you, and let's definitely work towards that. And I'm going to introduce you to my friend here. And I noticed that your blood pressure is really, really high, and I'm really concerned about your safety. And honestly, somebody's not going to be ready to talk to me about that, which is what I'm skilled at doing, until I'm really meeting their needs and their perceived needs and where they're at. And of course, let's say I'm ready to manage their blood pressure and they're ready to take a medication. Are they going to be able to keep a medication on their person? Are they going to be able to take it daily? Are they going to be able to reduce sodium in their diet when they're being fed at a shelter? Are they, all those other factors. So of course, housing is central to that. And I wish I were awesome at finding people housing, but my skill set in that is not really great. And that's why I have a team that I work with who knows more about these processes and is available on site where I'm at to do that.
Yeah, I totally agree with Karen. And for me, I believe that homelessness is indeed very complex. And it's not just about lacking shelter. It's being able to survive trauma, managing chronic illnesses, navigating the systems that often fail. And, when we bring healthcare to housing, we remove those barriers to create continuity. So, clients shouldn't be put in a position where they have to choose between, seeing a doctor or, keeping their housing. So we can be able to do both. And I'm glad that CCH is already doing that in bridging housing and health together, integrated health together. So we can do both at the same time so that our people, can gain trust in the services that we provide. They can gain that housing stability. And that is where integrated health comes in, which is not just a luxury, it's necessary, and where the seriousness of ending homelessness begins in integrating health, in incorporating integrated healthcare in housing. So that's my take.
Holly or Susan, anything to add?
No, I think those are both just really great examples that highlights why this is so important.
Okay, great. Oh, sorry,
Agree.
Susan.
I was just gonna say, have to agree.
Yeah, awesome. So I'll just remind everyone we do go to 1:15. I know we may have some folks fall off at 1. So I'm going to ask one more question to Holly, then we're going to ask a few questions from our folks attending, and then I'll do my all panelists question after that and leave folks around 1:15. But thank you to everyone who's come. If you are heading off at 1, I know we're during the workday during this one. So Holly, we were talking about sort of day-to-day of healthcare here, but I think there's an elephant in the room about the potential $800 billion in cuts to Medicaid on the horizon at the federal level. I know that over half of CCH's medical reimbursements come from Medicaid. I know that other CHCs are in the same position. So as an advocacy organization in the state that works with national partners, can you tell us where legislators are in the process and sort of what the advocacy efforts are happening to counter the potential changes?
Yes, absolutely. It's a big threat, I think, both to community health centers and to patients. And so our understanding is that currently the Senate is working on their version of the budget reconciliation bill, building on the House's budget reconciliation package, which is the One Big Beautiful Bill Act, and that passed the House earlier this month. Our current understanding is that the Senate is aiming to have a floor vote this weekend, Saturday or Sunday, with the goal of sending it back to the House for approval and having the president sign the bill on July 4th. And so I think, Alexis, as you said, nearly 50% of health center patients in Colorado have Medicaid. It's such a critical funding source for health centers and for their patients, and just would have huge impacts in the state. And so I can share a phone number in the chat that is, if folks would like to do some advocacy around this. It's for a call-in platform that's used by one of our advocacy partners, the Association for Community Health. And then I'll also share a link for an action alert through our National Association of Community Health Centers. Both of those are focused, specifically on Medicaid. And just encourage folks to reach out to their representatives and express your concerns.
Thanks so much, Holly. And I'll mention that we've been doing a weekly sort of federal update because things have been changing so quickly. So if you're on our list, many of the folks who attend this already are, you're getting that weekly update from us. We're also doing one internal, so any staff are also getting that. But often we are looking at or borrowing language from or working with CCHN, NACHC, other organizations, because we know that we're just one of many organizations being impacted by these potential cuts. So please do engage however you'd like with any of those organizations. So I'm going to try to address a couple of questions in the Q&A. I'm going to start with these 2 questions from James and Carol. They're a little bit similar, and I think that Susan might be really able to answer them well. So James says, how can people be served who can't and will never again be able to fully perform their activities of daily living or ADLs? So these are like being able to get yourself dressed, get to the bathroom by yourself, things like that. In other words, do we need permanent personal support in their housing? What do we do for folks like that? And then similarly, Carol says, what do we know about assisted living facilities in Colorado? How do we help people find these facilities and connect to them? So, Susan, as you're working at the Recuperative Care Center, any guidance on those?
Let's just start with the assisted living facilities. I'm becoming more and more familiar with them each day. I actually work with several here in the Denver area that are glad to help us with our clientele, to get them housed and to get them the care and the help that they need. We work with one in particular. It's called Blessings in Disguise. Her goal is to take anybody who is homeless, who cannot care for themselves, and so that she can make sure they get the care that they need. So we find these individuals, or we find these places that will help our clients. We do a lot of home health care. So if we have a client, say I have a client, they're going to discharge to an apartment, but they really and truly shouldn't be on their own, we're going to get home health care in there. We're going to make sure they have somebody coming in that's going to be taking care of them. That's most important, because we need them to be successful when they leave our facility, or when they get housed through the PATH program or through the clinic, or however it is. They need to be able to be successful. So we're going to do everything in our power to make sure that they're getting the support that they need for that achievement. And
Thank
I
you
hope
so
that
much.
answered it very well for them, but if not, I can always answer more questions.
Okay, thank you. One of the questions is, do you help people experiencing homelessness apply for Medicaid, SNAP, TANF, etc.? What about supporting to get vital records like IDs without an address? So I did quickly, I think after this question came in, speak to this about how we do have benefits administrators who help people at the Stout Street Health Center. I also, Susan, not to call on you again, but you were definitely talking about vital IDs, vital records like IDs. I think that, yeah, a lot of folks who are coming in through that pathway are those who don't necessarily have those. A lot get lost. A lot of people just didn't have them. They maybe moved a lot of times. Maybe things were swept. Can you tell us a little bit about like that process and how that all works?
For every case manager and does, the most important thing we do first is vital docs. So that's going to be ID, social security number, or social security card and birth certificate. After that, we work on SNAP. We make sure their Medicaid is up to date. We make sure that, do they need long-term Medicaid? If they do, we're going to apply for it. Do they need to recertify their SNAP? Are they in a housing program where they need to have their recertification done? We're going to help them with that. So anything along that line, we're going to make sure that that gets done for them while they're working with one of our case managers.
Thank you so much, Susan. We had a question from Jimmy. It says, with all the camping bans and sweeps and criminal prosecution in Colorado, I wonder if we should revise the health and stress data. I saw this question and it reminded me of a study that came through the National Healthcare for the Homeless Council I believe it was by Josh Barakis, and I'll go ahead and put the link to that in the chat. But essentially, this study, which was a local study, shows that involuntary displacement of people experiencing homelessness causes significant spikes in mortality, overdoses, and hospitalization. So I think that's a really great point, Jimmy, that like the consequences of camping bans and sweeps and criminal prosecution are something that if you just sort of stop and think about it real quickly, you would know this, but it's great to have the data to know that if someone sweeps your belongings away, and you lose your medication, you lose anything that you needed, that's going to affect your health. That criminal prosecution, spending time in jail, not having your medicine, having fines to pay, so maybe you had to spend your money there rather than on medicine, losing appointments, maybe you're incarcerated during appointments, that's all going to have negative health consequences. And so this study is a really great demonstration of that. I don't know if anyone else has thoughts about, if you have experience in your roles of seeing, working with clients or having experiences with someone who's having dealing with camping bans or incarceration, sweeps, and that affecting clients, if anyone has anything to add. Okay, no pressure. So I am going to ask one sort of wrap-up question. Basically, folks who are joining us today, those who watch afterwards, sometimes they're people who work in the sector, sometimes they're people who use our services, sometimes they're just community members who want to assist their neighbors. What do you recommend that folks do to assist individuals experiencing homelessness, whether that's broad, big picture, or small everyday tasks that people can do? We know these are difficult topics, and we always like to leave a little bit of, what can you do to help in our conversations? And so I'll go ahead and maybe I'll start with Karen. Sorry to put you on the spot.
No, that's great. So maybe this audience already has their hands in working with people with homelessness, but I often get asked this question in my own personal community, where a lot of folks don't interact with people experiencing homelessness. And often what I tell people is to think about their employers and what their hiring practices are. We know that a history of incarceration is a major pathway for homelessness, and it's one area that I could see some very key changes happening if organizations, large companies, really looked at their policies around hiring people with a background of incarceration. And so I think it's something we can all think about. I know CCH definitely hires people with past histories. Obviously, there are some roles that doesn't work for based on licensing, but other people should be thinking about that.
I would want to say that healing starts with connection. And this is where our communities, come in. Our communities must, help by advocating for policies that protect and expand, Medicaid and integrated care funding, especially as we face potential, federal fund cuts. But beyond the policy, we need a shift of perspective. We need to understand that homelessness is often a result of untreated, trauma and systematic failure, and it's not a personal choice. So our communities can support organizations like CCH that are doing the work already. We need more people to volunteer in this sector. We need more donations. So we're calling upon the community to come in and support the work because, like I said, healing starts with connection. We need to see our communities treating the people that we serve, our homeless communities, with dignity. And this awareness, I'm very, very glad that this meeting will even be put on YouTube. We need more awareness about homelessness and how we can be able to appreciate that it's not a personal choice that people are homeless, but homelessness happens because of these untreated trauma and systematic failures. So we call upon our members of the community, our leaders, to support the work and understand. Create your own awareness in understanding why people are homeless. So that is my take on that. Thank you.
For myself, I guess I would have to say, listen to the individuals that are out there. And something that I recently just told somebody in my family was, and Winnie already said this, is treat them with dignity. I mean, they go through so much trauma on a daily basis that when people walk up to them and they treat them like a piece of dirt or like they're non-existent or they're just not there, it just adds on to that trauma on a daily basis. And it's hard for somebody to get out of that hole if it keeps getting lower and lower and lower. But just listening, sometimes just sitting down, talking with somebody who's experiencing being unhoused, listening to them, just being a friend and a friendly ear is sometimes one of the best things that you can do for them is just, sometimes they just need that. One of the things I've learned the most important lesson I've learned since working with individuals unhoused is I am literally one life event away from being right where they are, especially in today's economy and market. And I have met people who have been homeless for 20 years. I have met people who were married, employed, had a house, and they got sick, lost their job, their wife died, and now they're homeless for the very first time ever. So you just never know what that individual is going through. And I just want to do and be kind to the people that I'm servicing so that that's just it. I see so much that they go through on a daily basis that just be kind. Just be kind and just listen to things that they have to say.
Thank you so much. Holly, any last thoughts?
No, I think really resonate with just recognizing our shared humanity and then thinking about at that big picture level those advocacy efforts. So just really appreciate what each of you shared.
Thank you all so much. Yeah, we're going to go ahead and wrap up now. We're almost at time. So first and foremost, I want to thank all of our amazing panelists. I learned a lot today, and thank you all so much for sharing. Also, I want to thank the education and advocacy team who helps put these on. So that includes Andrew West and Shannon Webster. Gabriella Visani, Kathy Alderman, our fearless leader, and Aubrey Wild. So thanks to the team and to everyone at CCH. It's so great that when we conceptualize a topic and then I get to have this time with my colleagues who I often don't get to speak deeply with. And so thank you all, and thanks to Holly, of course, from CCHN, who we count on as such a robust partner. This was our first lunch and learn ed series for quite some time. So let us know what you thought of that. We're trying that again next month. We thought it would be like a good summer vibe. And we're doing support-centered housing and evidence-based solutions. So we're really talking about why permanent supportive housing is the model that works. Other models work as well that are not housing first, but they just don't work as well according to the data. So we're going to sort of dig into that, talk about it with some experts in the field. And please do take our follow-up survey in Zoom. And then we'll see you for a couple more of these sessions for the rest of the year. You can always watch older ones on YouTube, and please follow us on social media if that works for you. Thank you all so much for taking the time to come, and we'll see you next time.